Hi, and welcome to today's presentation. It's entitled Discussing Referral and Treatment Options with Adolescents. I'm Christina Dryman, and I'll be presenting today's session. I also want to recognize Tracy McPherson, who serves as joint faculty on this initiative and has led many of the adolescent SBIRT initiatives at NORC. The information shared in today's session was developed by NORC at the University of Chicago and its partners with funding from the Conrad N. Hilton Foundation. So let's begin by talking about general issues pertaining to referring adolescents for treatment for a substance use problem. So a small percentage of adolescents will require a level or intensity of treatment beyond that of which the practitioner may be able to provide from just a brief intervention. So those adolescents may be referred to a specialty treatment facility that offers residential and or outpatient treatment programs. Adolescents who enter treatment are referred from a variety of sources. This chart shows the breakdown of adolescent substance use treatment admittances by referral sources. And this is according to the 2004 to 2014 treatment episodes data set. And you can see here, of those admitted to treatment, most, around 44%, were referred from the court or criminal justice system, but nearly 20% of admissions were self-referred, and 13% were from schools, which really underscores the importance of the brief intervention and the integration of SBIRT services into school-based settings. And so brief intervention encourages you to take positive actions around their substance use and offers the practitioner the opportunity to provide information about treatment options and to support the adolescent in gaining insight when treatment is needed. So unless under a court-ordered mandate, the adolescent must be agreeable to participating in treatment. How the practitioner broaches and discusses referral contributes to the likelihood of successful treatment. In contrast to adults, adolescents are often less likely to feel that they need help or seek treatment on their own. And developmentally, adolescents have a harder time recognizing their own behavior patterns than adults. This is in part due to the fact that adolescents have shorter histories of substance use and therefore are unlikely to have experienced as many adverse consequences from their substance use compared to that of adult users. And so fewer adverse consequences can mean less of an incentive to change or to engage in any type of intervention or treatment. So engaging adolescents really requires patience and an open and empathic therapeutic stance. There are several considerations with respect to the involvement of parents in the treatment referral process. So depending on the age of the adolescent, the degree of acute risk, and state regulations regarding access to healthcare by a minor, it may be necessary to involve the parents or guardians of the adolescent, regardless of whether or not the adolescent consents. Breaking confidentiality in this situation can be challenging, so it's important for practitioners to be familiar with legal issues associated with maintaining or not maintaining confidentiality. It's also important for the practitioner to be supportive during conversations with the adolescent and parents about the adolescent's care options. Motivational interviewing strategies can be used to encourage both parties to accept a referral. A couple of strategies you can use when dealing with pushback to a recommendation for referral to treatment include encouraging parents or guardians to have an honest and open conversation with the adolescent, guiding the parent to use motivational interviewing skills with the adolescent. The parent can be a major influence agent in getting the adolescent to agree to services, and they can explore the pros and cons of getting help and changing health behaviors, and also discuss the benefits of professional help. Referrals or handoffs for a level of intensity of treatment beyond that of which the practitioner can provide are challenging in virtually any endeavor, perhaps more challenging with adolescents, particularly if he or she doesn't think there's a substance use problem. Far too many young people are lost to the system during handoffs from one level of care to another. So it's important for providers to keep their list of referral resources current to review and confirm the list annually, and to proactively reach out to new potential sources to build their referral network. David Gustafson, well known in the substance use treatment field, has extensively studied the characteristics of handoffs in diverse settings such as surgery and postoperative care, air traffic control, and 911 calls. These studies found that all situations require a smooth handoff, and a failed handoff really disrupts service delivery and introduces errors, sometimes with disastrous consequences. So in the resources section at the end of this presentation, there are four slides which describe the 8 key principles of effective handoffs, which can dramatically improve the transition of clients with a substance use disorder between levels of care. So now we'll turn to a discussion of when a referral for treatment or other types of clinical services is advisable based on the SBIRT model. So there are 3 reasons. The first is that the use score on the screening tool is very elevated and suggests a high risk status. And in some cases, the brief intervention has been bypassed. A second reason is that there's no progress during the brief intervention. And the third reason is that other health issues, such as co-occurring mental or physical health disorders, are identified during the brief intervention that merit more critical attention. And again, using your clinical judgment is always critical during this process. So the American Society of Addiction Medicine, also referred to as ASAM, suggests practitioners use the following 6 dimensions to determine the appropriate intensity and length of treatment for adolescents with a substance use disorder. First is the level of intoxication and potential for withdrawal currently and in the past, the presence of other medical conditions currently and in the past, the presence of other emotional, behavioral, or cognitive conditions, readiness or motivation to change, risk of relapse or continued drug use, and lastly, the recovery environment, such as family, peers, school, and the legal system. You can learn more about the ASAM criteria and training at www.asam.org. So what are some of the most common settings in which adolescent substance use treatment occurs? Well, there are 3. The most commonly offered treatment setting is outpatient, intensive outpatient services. And it can be highly effective and is traditionally recommended for adolescents with a less severe substance use disorder, fewer additional mental health problems, and also a supportive living environment. Studies have also demonstrated that more severe cases can be treated in intensive outpatient settings as well. The second is partial residential, and this setting is indicated for adolescents with a severe substance use disorder and who can be safely managed in their home living environment. And so a typical partial residential program has adolescents participating in 4 to 6 hours of treatment per day, at least 5 days a week, while still living at home. And third is residential inpatient treatment. And this is offered to adolescents with severe levels of substance use disorder, mental health issues, and perhaps medical needs, which require a 24-hour structured environment. Treatment in a residential setting can last from 1 month up to 1 year. The major treatment and recovery approaches to treat adolescents with a substance use disorder include behavioral approaches, such as cognitive behavioral therapy, family-based approaches, such as brief strategic family therapy, medication-assisted treatment, recovery support services, such as peer recovery supports. And you can learn more about effective treatment approaches for adolescents on NIDA's website, which is linked here. And another issue is determining the most appropriate referral sources. So of course, every adolescent is different and has varying needs when obtaining assistance. And so practitioners consider the many multicultural factors that impact the treatment process. This includes race, gender, religion, spirituality, primary language spoken, as well as geographical constraints, financial factors, including insurance coverage and out-of-pocket expenses. All of these things need to be considered when making a recommendation, so the adolescent can be matched with the most appropriate referral source. And it's optimal if the practitioner can assess and whenever possible remove or minimize potential barriers to successful engagement with the helping resource. So potential barriers can include lack of access to child or elder care, lack of financial resources, transportation needs, fear that others will find out, lack of family support, legal complications, medical needs, just to name a few. And so identifying and addressing these barriers can help ensure the client accesses the assistance or treatment resources available to them. And then there is the importance of explaining to the client in clear and specific language the necessity for and process of referral to increase the likelihood of understanding and following through with the referral. So listening and responding openly to questions and concerns by adolescents or parents and guardians will help to minimize pushback. Again, it can't be said enough, the importance of the practitioner taking an active role and engaging a referral to the appropriate service or resource. So the American Academy of Pediatrics recommends that practitioners establish working relationships with substance use treatment providers in their communities to ensure their adolescents have treatment options that are developmentally appropriate. And it's preferable for the referral to be arranged immediately using a warm transfer where the practitioner connects the adolescent directly with the treatment provider by telephone while the adolescent is still in the office. At a minimum, the adolescent, and in most instances, the parent, must be provided with a written referral to the treatment provider's contact information, address, and date and time of the first appointment or meeting. The speed at which you can link an adolescent to treatment dramatically impacts their likelihood to show up, remain in treatment, and experience positive outcomes. And so the first 24 hours after an adolescent's initial contact is a critical period in initiating a stepped-up treatment. And this short interval may not be realistic, but research shows that if the gap between your session and the first appointment for a different level of care is more than 14 days, failure is virtually certain. So offering a treatment appointment date immediately and then reminding the adolescent of their initial scheduled appointment usually improves the rate at which adolescents will begin treatment. Also, it's important to have a discussion about what adolescents can expect from treatment. Adolescents generally don't know what to expect other than what they may have experienced or received from the brief intervention. And if appropriate, the practitioner can also follow up with the adolescent to see how they're progressing, regardless of whether or not a referral is provided. And when a follow-up is presented as sort of the standard of care conducted with all adolescents and young adults, it's likely that you'll get agreement from the adolescent. So I'd like to quickly share some additional resources for future education and learning about referring adolescents to substance use treatment. To learn more about referral, the Using SBIRT to Talk to Adolescents About Substance Use four-part webinar series offers a series of on-demand learning called Discussing Options and Referring Adolescents to Treatment. You can access this on-demand webinar at sbirt.webs.com/webinars. We also suggest reviewing the Learner's Guide to Adolescent SBIRT, specifically Module 4 on referral to treatment and follow-up. You can request a free copy, electronic copy of the Learner's Guide at sbirt.webs.com/curriculum. And here's a list of video resources regarding the process of referral to treatment. There are excellent resources from the Boston University's BNI Art Institute, which has 4 videos listed here. Also the SBIRT Oregon website, and then the University of Florida Institute for Child Health Policy and Cherokee National Behavioral Health. This slide offers websites for locating treatment services and specialists. Sources include SAMHSA's 3 locator sites, as well as sites from the American Society of Addiction Medicine, the American Academy of Addiction Psychiatry, and the American Academy of Child and Adolescent Psychiatry. And if you're interested in additional resources about recovery models and services, here are several. There's resources on recovery high schools, recovery schools for higher education, SAMHSA's Guide to Peer Recovery Support Services, also some resources on mutual support groups, such as Alcoholics Anonymous and Narcotics Anonymous, and then also the documentary series from HBO, Addiction, entitled Drug Treatment for Adolescents. And as I mentioned before, this is the list of Gustafson's 8 key principles of effective handoffs, which can dramatically improve the transition of clients with a substance use disorder between levels of care. And so the first is commitment. The practitioner must believe that the handoffs are essential for each adolescent and the organization as a whole. The second is responsibility. So non-compliance of the adolescent is the reason practitioners should devote more attention to successful handoffs rather than using it as an excuse for failing to do so. And it's the practitioner's responsibility to ensure the adolescent is transferred to the appropriate care. The third principle is understanding the client. So practitioners must respect and incorporate both the unique needs and circumstances of adolescents in managing referrals. Fourth is designation and clearly defined roles. So both the practitioner initiating the referral and the practitioner receiving the referral should have clearly defined roles and a history of the adolescent's experiences. The fifth principle is presence, meaning the adolescent should be accompanied by a practitioner throughout the entire referral process to ensure timely follow-through and a smooth transition. The sixth principle is common language for handoffs, meaning practitioners should use language that both the adolescent and or parent or guardian can understand. The seventh principle is practice. Essentially, the more a practitioner practices these skills, the better they'll become at doing them. And then lastly, monitoring, evaluation, and improvement. So when integrating SBIRT into practice, practitioners need to establish mechanisms for monitoring the success of handoffs from one level of care to another and use those results to ultimately improve their care. So that will conclude today's session. Thank you so much for joining.